So basically, my talk. Good morning, everybody. Antibiotic resistance in patients with cancer, escalating challenges and paths forward. So I've been given 15 minutes to talk on this topic. Let me see whether I do justice to that. So some general principles in evaluating infection. So it is just not antibiotic. Whether I give meropenem or whether I give colistin or whether I give ceftazidime, bactam or I give phosphomycin. It is not that way. It is just not what antibiotic. But each ID problem has seven components. What is the syndromic diagnosis? Whether it is a respiratory GI or whether it's line-related infection. Is it community-acquired or healthcare-associated infection? That's the second question which comes to my mind. What is the microbiological etiology which causes this syndromic diagnosis? Whether it's a lung, abdomen, your organisms are different, and so your antibiotic choice would be different. So that's very, very important. It is just not shooting an broad antibiotic. You have to know what you're treating. What is the pattern of that resistance, whether it's community acquired or healthcare associated, or what is the resistance of that organism in your hospital ICU ward? That is very, very important. What is the right choice of antibiotic for that organism for that syndromic diagnosis? Does the choice of antibiotic reach whatever you're giving? Does they reach the site? For example, many people will have E. coli urinary tract infection and it will be sensitive to colistin TG. A creatinine is 1.3, and I would be hesitant to give colistin and might give TG. But TG is the right choice of antibiotic. The resistance pattern also it is correct, but it will not reach the urinary site. So there is no point in giving TG in spite of being sensitive. So that's where there's a choice of antibiotic reach the site is very important. And the antibiotic given, whether the pharmacokinetics and pharmacodynamics, what you're giving, is it achieving whether you're able to achieve or not. Keep non-infectious fever in mind. Always, whenever you're doing a blood culture, see that you don't send one bottle or two bottles. It has to be minimum two sets of blood culture. That means 10 ml per bottle. So it should be 40 ml blood what is required. So it will be 20 ml from a right hand or left hand or from a central line or pit line. So it has to be minimum of 40 ml of blood. The more the blood, the chances of picking up the organism if the patient is bacteremic would be higher. So these are certain principles when you're evaluating infections in not only cancer patients or whether hemopatic stem cell transplant, any patient, the principles of ID remain the same when you're treating or when you're choosing your antibiotic. So I think if you remember your seven principles, possibly you would go majority of the times correct in choosing your antibiotic. That's very important. I'll just come to this case. She's a 27 years AML undergone chemotherapy with cytarabine and daunorubicin. Patient is otherwise quite stable. Whether should you give antibacterials, antifungals, antivirals? Yes, the antibacterial definitely no role. Antifungals, you would start the patient on posaconazole or some azole-based therapy to prevent a mold infection, even the start of the chemotherapy, because posaconazole or isavuconazole also would take anywhere from 3 to 7 days. Like especially posaconazole would take 7 days for the levels to reach. So you would start for an induction chemotherapy for AML or maybe multiple myeloma, myelodysplastic syndrome, but predominantly for AML. No role of antivirals. So on routine examination day 10 after the induction chemo, the WBC count is 600. Patient is afebrile. Next day, day 11, the ANC is 400. Now the question is, the ANC is 400. Patient is not febrile. Should you give an antibacterial drug? Should a antibiotic prophylaxis be given to prevent an infection? So what would you do? I would start meropenem. Just so neutropenia, ANC is 400. It further dropped down to 100. So without fever, would you give Mero plus Tico, Cipro plus Amoxiclav? This is the Western guidelines, piperacillin plus Tazobactam, or observe without antibiotic. So what would you do in India when you have a patient who is severely neutropenic but not running any fever? So I think you'll have to assess whether it's a low risk infection, intermediate infection, or high risk infection. But what is the reality in India is that 80% of the Enterobacteriaceae, that is E. coli and Klebsiella pneumonia, are ESBL. That means they are resistant to your third generation cephalosporins, or they are resistant to your ciprofloxacin or even amoxicillin clavulanic acid. So the Western guidelines do not really imply to India, and so the minimum, if at all you want to start a drug, would be to prevent, just like the Western people give quinolones plus amoxicillin clavulanic acid. We would be using piperacillin tazobactam or ciprofloxacin, but that's not the right way to go about it because we hardly have any antibiotic left behind after using these drugs. So the best thing is not to use any prophylaxis if the patient does not have fever. And even this guideline says that whenever the pattern of resistance is more than 20% in the community, you are not supposed to use those drugs. So the Western guidelines do not hold true for us. If the patient is neutropenic, severely neutropenic, but not running any fever, giving a prophylactic antibiotic in India is not a choice. Only when they have fever, you would give it. So what about the carbapenem resistant rates in India? If you see, different hospitals will have different, or different cities will have different rates of resistance. But most striking is that Acinetobacter is close to 85 to 100% resistant hospital-acquired infections, which will be resistant to carbapenems. Klebsiella would be around 50 to 70%. Pseudomonas would be anywhere from 40. This is 2015, so I'm increasing the resistance. So it will be 47 to 50%. So the question is, till 2018, we always thought that every carbapenem resistant Enterobacter, that is E. coli, Klebsiella, or Enterobacter, which we the most commonly which we encounter, is having an MDM production. So MDM production is significantly the most common mechanism for CR in India. That was what thought in before 2018, and the reason for that is everybody was then given colistin based therapy. So that was but I think things have changed now. I'll come to that why we say that every CRE, every carbapenem resistant Enterobacter is not a MDM production. It may be a different mechanism of resistance, and you may have options apart from your colistin or polymyxin B based therapy. It is also this statement is true that all MDM producing Enterobacter isolates are ESBL production also. That means they are easily destroyed by the extended spectrum beta lactamase production, and that is what is holds true. So we have these various beta lactamases, serine and metal enzymes. B is the MBL, which is called as the New Delhi metabolite beta lactamase enzyme. But serine enzyme, we have class A is the ESBL, what we see. Class D is the OXA 48. OXA, this is very important. I'm going to discuss about this OXA and then the AMC. So the main discussion is going to be between NDM and OXA 48. And we have this, we don't have KPC in India. We have VIM, WIL is predominantly seen in Pseudomonas. And I think every antibiotic has a different breakpoint for different organisms. Like the same meropenem would have a breakpoint of for Enterobacter is 1, for Pseudomonas it is 2, and for Acinetobacter it is 4 or 8. So NDM production is significantly the most common mechanism of CR in India. This is not true. This till 2018, 2019 we were saying that this is the mechanism of resistance, but that statement is not true, and I'll show you from my paper where it says that NDM is not the only mechanism of production, and we have options for different antibiotic apart from colistin or polymyxin B. What do we know about the Oxford Carba test? So Carba test is done whenever you have a Enterobacter, that's E. coli or a Klebsiella or Enterobacter, you can subject that patient for a Carba test, and this test you can see that this is carbapenem resistant, it is meropenem resistant, but this is not NDM. We used to always think it is NDM. It is not NDM, but it is OXA 48. So when you have an OXA 48 Klebsiella, you have an option apart from colistin or polymyxin B, and possibly you can use ceftazidime avibactam. But it's very important. Whenever you use ceftazidime avibactam, see that you can start the treatment with ceftazidime avibactam, but it's important that you demonstrate the susceptibility by phenotypic mechanism resistance. That's very important. Now let's come to this case. This is an 18 years male. This patient has been just discharged a week back from Leelavati Hospital. So this is an 18 years male diagnosed as acute myeloid leukemia. He underwent an induction chemotherapy recently with cytarabine and daunorubicin. Had received meropenem for neutropenia in the last admission for fever. He's on posaconazole prophylaxis. His MRD is negative. That means he's a good patient for a bone marrow transplant. And now for the second time, he was admitted for a consolidation therapy. He received a lesser dose for cytarabine because he's MRD negative. He has a PIC line which is 45 days old. He has severe neutropenia and he's developed his ANC is only 20. Absolute neutrophil count is 20, and he develops a new onset fever. He has severe oral mucositis and he had mild dysphagia. He doesn't have any perirectal excoriation or tenderness. So that means there is no perianal abscess or excoriation. But he has mucositis in the oral mouth cavity. And another risk factor is that he's got a PIC line which is 45 days old. He's hemodynamically very stable, fully mobile, not breathless, not tachycardic, hemodynamically very, very stable. So what would be your choice of antibiotic for a patient who has got an ANC of 20, okay, with a prior meropenem with a prior meropenem exposure, and he is having a PICC line and a severe mucositis. So again, the same general principles in evaluating infection. What is the syndrome? So here the syndromic diagnosis would be, it could be a PICC line related infection, or it could be translocation from the mucositis. So if it's a PICC line related infection, it could be a wide one, it could be gram positive, it could be gram negative, it could be a sensitive gram negative, or it could be multi-drug resistant, carbapenem resistant gram negative, because he has a prior meropenem exposure and multiple hospitalization. So he's a risk for carbapenem resistant organism. I'm saying CRO. When I say CRO, means it is E. coli, Klebsiella, Pseudomonas, Acinetobacter. When I say CRE, that means it is E. coli or Klebsiella or Enterobacter. In CRE or Acinetobacter and Pseudomonas do not come into the picture. So what is the syndromic diagnosis? Either it's a PICC line related infection, which could be anything. It could be the Burkholderia cepacia also, because water is a very good source for B. cepacia. And your oral mucositis, it could be a gram positive, gram negative, or it could be candida. So all these things will come into the mind. Second thing, is it community acquired or healthcare associated? Possibly this could be both. It is more likely to be healthcare associated. What is the microbiological etiology? I think I just discussed. It's a wide one. It's very difficult to judge what it could be, and what could be the pattern of resistance. That also I discussed, because he has a prior meropenem exposure, multiple hospitalization, and what would be the right choice of antibiotic, and thus the antibiotic reach the site. So before going for antibiotic, check the oral cavity, perianal region, look for abdominal tenderness, styphlitis, sinus tenderness, skin and soft tissue, any lines and catheter. Since this patient was hemodynamically stable, hematologist referred us, and we decided to start and continue only on meropenem and teicoplanin after sending two sets of blood culture, one from the PICC line and one from the peripheral line. So we gave him meropenem and teicoplanin. We thought, let's not escalate directly. We'll wait because he was very stable. Fever persists after 48 hours of giving meropenem and teicoplanin, but he's also severely neutropenic. So we don't know whether it's a neutropenic fever. So we added micafungin because he had severe oral mucositis. So candida is one possibility. We thought that till the blood cultures come back, we would do this because his ANC was only 20. Now the blood cultures are referred to as is growing a gram negative bacilli. Now the question is it a carbapenem resistant organism, CRO, or is it a ESBL? If it's a ESBL, exponent spectrum beta lactam is producing organism, then possibly your meropenem will work. Then why do you want to give colistin or not? So that question is there. But what can you do to quickly know whether it's a CRE or ESBL? You can do a BCID, that is blood culture identification by biofan, BCID2. And these are the risk factors like last 90 days, hospitalization, prior antibiotic exposure. And this slide already has shown you. So the question was whether after knowing it's a GNB, should I continue meropenem? Should I continue mero plus add phosphomycin? Should I give colistin plus meropenem or colistin plus phosphor, ceftazidime? So this is a whole basket of drugs which is there in front of you, which you can use colistin plus minocycline or colistin plus tigecycline. So it becomes very difficult. But if you have facility for a BCID2, you can quickly look at to know the resistance and your treatment of choice. And this is a BCID. I'm sorry for it. Possibly you may not be able to see on your laptops. It is showing that it is Enterobacter detected, if you see this baseline. And then it is showing that it is CTXM, that means it is ESBL, and it is also showing that it is NDM. So NDM means your meropenem will not work, and the organism isolated is E. coli. So now you have more information that it is E. coli and it is NDM. So this patient is on meropenem, so any changes to be made. So again, whether you will use colistin plus mero, you will use colistin plus phospho, ceftazidime avibactam plus colistin, or will you use ceftazidime avibactam plus astringent plus colistin, or you will use ceftazidime avibactam plus astringent, or will you use colistin plus minocycline or colistin plus tigecycline? Now let me come to each of these drugs. Colistin is whenever you don't know a CRO, the best drug to use when you have a carbapenem resistant organism, the best drug to use is a colistin or polymyxin based therapy, because it's got a very broad spectrum coverage, because it will cover 99%, it will cover all your MDR, Acinetobacter, Pseudomonas, E. coli, Klebsiella. Okay, mero will not cover any of these, but you can use in the combination colistin plus meropenem. So we continued meropenem at a higher dose, giving over 3 hours, 8 hourly, for the better pharmacokinetics and pharmacodynamics, but we added colistin to this patient. The second option was, could I have used colistin plus phosphomycin? But you should know each and every drug and their coverage of that organism, of that drug to the organism. Now, phosphomycin is a drug which will cover your E. coli close to 99 to 100%. Okay, MDR, multi-resistant E. coli. It will cover Klebsiella only 50%. It will not cover Acinetobacter, 0% coverage, and maybe 20% Pseudomonas. So phosphomycin is best for E. coli. So possibly I could have used colistin plus phospho as an option, but I did not want to expose this patient. He was hemodynamically very stable, so I continued to use colistin plus mero. Coming to the next question, should I use ceftazidime avibactam plus colistin? Now everybody feels, I want to give this information or message that ceftazidime avibactam is a very narrow spectrum drug. Okay, if all of you feel that the new drug ceftazidime avibactam is a good great drug, it is a very narrow spectrum drug because it does not take care of multi-drug resistant pseudomonas. It will not take care of acinetobacter at all. It will not take your E. coli, which is, it will not take care of E. coli close to 99%. It will not take care of your E. coli if it is a MDR E. coli. And Klebsiella, if it is OXA 48, if it is only OXA 48, that means among the carbapenem production, OXA 48 in Klebsiella is 40%. That means only chance that it will cover Klebsiella is 40%. So in short, ceftazidime avibactam will not cover Pseudomonas, will not cover Acinetobacter, will not cover E. coli if it is carbapenem resistant E. coli, and will cover Klebsiella only 40%, and that too if it is OXA 48. So it becomes a very narrow spectrum drug. I would never use this drug unless I have the sensitivity. What about ceftazidime avibactam plus astronium plus colistin? Now, colistin, of course, will widely cover, but when a companion drug you want to add, ceftazidime avibactam plus astronium together will not cover Pseudomonas, will not cover Acinetobacter. It will cover very well Klebsiella to more than 95%, but E. coli only 70% coverage. Okay, because earlier 3-4 years back it was covering 100% E. coli, but nowadays because of PBP3, that is penicillin binding protein 3, the coverage is only 60 to 70%. So there's a 40% chance that you will fail for the E. coli which this patient has. So there's no point in adding. So it's a very narrow spectrum drug. If everybody, because I've seen many people writing ceftazidime avibactam aspirin and they feel that is, will take care of everything. It's a very narrow spectrum drug compared to colistin. CZA, no choice. What about colistin plus minocycline? Decent choice because you have a line-related infection, Burkholderia, cepacia, and all that could be a possibility. But colistin plus meropenem would also take care of the this thing. Colistin plus TG, high dose TG could be an option that could have been used. So, in short, I would say when you don't know what is your CRO, best is to use colistin or polymyxin B. If it's a urinary tract, then use colistin. Polymyxin B doesn't come in the urinary tract. So, colistin plus mero or colistin plus mino would be a good choice. Ceftazidime avibactam becomes a narrow spectrum. And if you see this study, which we have made in 2019, this paper in IJCCM, where we saw that Klebsiellas, out of 40 Klebsiella, 38 were OXA 48. That means your ceftazidime avibactam will work. But another 40 were Ondium plus OXA, whereas ceftazidime avibactam will not work. That's why I said 40% will work. But when it comes to E. coli, all are NDM or NDM plus OXA, and your ceftazidime avibactam alone will not work. And that's why I say it's a very narrow spectrum. Coming to phosphomycin, I told you Klebsiella, the coverage is around 60%. E. coli is only E. coli is almost close to 100% susceptibility. And this is a sandwich technique. What we do, or we do a D test, ceftazidime avibactam disc, which is Klebsiella, which is resistant to ceftazidime avibactam because NDM plus OXA, and you'll see all resistant. But when I place an astronium disc in front of it, you'll see that astronium is also resistant, but in between there's a lot of clearing of zone. So the good drug is ceftazidime avibactam plus astronium is a good drug for Klebsiella only. So it's a very specific drug-specific drug. Here also it says CZ is resistant, astronium is resistant, but when you put it, there are two discs, ceftazidime avibactam plus astronium. When you combine this, you nice zone of inhibition. This is only for Klebsiella. It will not. 70% may work for E. coli, Pseudomonas and Acinetobacter. It will not work at all. So he was started on colistin, high-dose meropenem, PICC line was removed, did not get the DTP to decide whether it's a PICC line or translocation of the mucositis. 10 days of treatment, discharge, and he's for bone marrow transplant. The options were that we could have used these combination. I think I'll skip this for a time, and I will go to another. This was a Klebsiella. This case was the patient with Klebsiella pneumonia, again acute myeloid leukemia, and the organism was Klebsiella and it was OXA 48. So here the combination of colistin plus Zevicepta alone would do, or ceftazidime avibactam, or only ceftazidime avibactam would also do. So I'll just come to this last case. ICU for neutropenic. This patient was in the ICU for neutropenic fever. He develops a new onset hypotension. And when he develops a new onset hypotension, this patient is already on colistin plus meropenem plus teicoplanin. He has a central line and he has 32 days stay in the hospital. Okay. So he is already on colistin, meropenem, and teicoplanin for a sepsis where he recovers, and then after recovery he develops a new onset fever on colistin, mero, and teicoplanin. So you are widely covering gram negative, you are widely covering gram positive, but your new onset fever is on colistin. So and the blood culture is growing GNB. So is it multi-drug resistant or is it a resistant colistin resistant pseudomonas? Is it a colistin resistant E. coli? Is it a colistin resistant Klebsiella? Or is it a colistin resistant Acinetobacter? So that is a possibility. But whenever a patient has got a colistin prior exposure, the most likely organism would be a colistin breakthrough pathogen. That is usually it is B. cepacia, Chrysobacterium indulgens, also called as Elizabeth Kinge, or it could be Stenotrophomonas maltophilia. So much of widely colistin and polymyxin B is being used that the more and more colistin we use, and if the patient develops a GNB in the blood on prior colistin exposure or on colistin treatment, we should always suspect that are we dealing with a Rhizobacterium indulgens or Elizabeth Kinge, which is called as, or is it B. cepacia, or is it Stenotrophomonas maltophilia? And the drug of choice, safety wise, would be to use this in your clinical practice for your hematological patients would be minocycline, 200 stat and 100 BD, because it would take care of all these three pathogens. Ceftriaxone, that is trimethoprim sulfamethoxam, is a choice, but all your cancer patients are neutropenic with thrombocytopenia, so that doesn't become a good choice. So here the choice would be whenever you have a colistin or colistin breakthrough pathogen, this would be the choice. So we are waiting for a lot of drugs. If you see this chart, ceftolozane tazobactam, this is only good for Pseudomonas, which is not available in India. Ceftazidime avibactam is available in India. It will take care of, uh, I said, 40% of your Klebsiellas, but and around with along with Astronam, like Astronam avibactam, it would take almost 95% of your Klebsiella, but very 70% of E. coli and nothing to do with Pseudomonas and Acinetobacter. What we are waiting is for Meropenem norquebactam, or we are waiting for Astronam avibactam, or we are waiting for uh, Cefepime sidrobactam. So that is the drug which we are waiting, which will be taken care of. So in summary, all what we thought about CRE mechanism as NDM, 40% is OXA48, and we have choice of this happens only in Klebsiella, and the choice would be ceftazidime avibactam. If OXA48, then colistin sparing therapy, ceftazidime avibactam is available. In India, nosocomial always GNB, and when we do not know which GNB, consider it as a CRO, carbapenem resistant organism, and it will be colistin or polymyxin B based therapy. Monotherapy or combination therapy will depend on the clinical severity of the presentation. Poly B or colistin clinical efficacy same with minor differences. Poly B doesn't come in the urinary system and should not be used for UTI. Tigecycline is good for intra-abdominal infection, for bacteremia. Use high dose tigecycline. So we I think switch to using 200 stat of tigecycline and 100 BD, which takes care of the bacteremia also. It's a good drug which does not take care of protease and pseudomonas. Phosphomycin good to combine with colistin if CRE is sensitive. Usually E. coli 95% sensitive to phosphomycin, 60% to Klebsiella, does not work on pseudomonas well and does not work at all on Acinetobacter. Minocycline more for colistin breakthrough pathogens like Elizabeth Kinge or Chrysobacterium indulgens, Stenotrophomonas maltophilia, or B. cepacia. So ideal drug for CRE, NDM or NDM plus OXA48 is Astronam avibactam and cefiderocol and cefepime sidrobactam, which is still not available. Cefiderocol is also not available in India. So thanks for your attention. It was only 15 minutes talk, so I couldn't cover extensively whatever I could cover. I'll be happy to take any questions.